I've been to India twice, and I love everything about India. And about 20 to 25% of my patients are actually Indians in here. I'm right outside Washington, where all the high-tech companies are. So most of the patients I have are from the south of India, but there's from all over India, but about 70, 80% are from southern India. So I'm very well aware of the culture. I'm very aware of the diet. So we can open these during the Q&A. But I'm going to talk to you today about a problem that everyone faces, which is what do you do with these outliers in IVF? High responders are a problem. Poor responders are a problem. How can we give our patients the best treatment possible? So before I start, I want to do the survey first. So if you can see the survey in there, it's 6 questions. So I'm going to take a poll first and then do my talk. And then after the presentation, I'm going to do another poll. So the first question, what do you think are effective strategies to decrease hyperresponse? Do they include the following? 1, insulin sensitizer pretreatment. B, dopamine agonist use. C, GnRH antagonist protocol. D, HP-HMG use. And E, all of the above. The second question, when faced with a patient at high risk of OHSS in a GnRH antagonist cycle, A, trigger with HCG and transfer. B, cancel the cycle. C, trigger with GnRH agonist and freeze all. D, trigger with GnRH agonist and transfer. The third question, the use of HP-HMG in high responder is associated with A, higher OHSS risk. B, same OHSS risk. C, lower OHSS risk. And question 4, proven strategies in poor responders include the following. A, increasing gonadotropin use. B, using GnRH antagonist protocol compared to GnRH agonist. C, adding recombinant LH. D, androgen pretreatment, specifically DHEA or testosterone. Question 5, poor responders may benefit from A, 2 to 3 months course of androgen. B, addition of growth hormone. C, maximizing gonadotropin dose at 450. D, embryo banking. E, all of the above. And last question, using recombinant LH in addition to recombinant FSH in poor responders compared to recombinant FSH only is associated with A, higher oocyte and embryo number. B, same oocyte and embryo number. And C, lower oocyte and embryo number. So I'm going to give you 60 seconds to try to answer these, and then we'll see the poll results, and then we'll start.
All of you, the required answers that you feel is the correct one, you can just click on that, and at the end of the 6th question you find a send vote button. You can press on that button once you are done with all the 6 answers. And Dr. Fandi would show you all the responses. Once everyone has voted, we would share the result, and then we would start the presentation and take the same questions again after the presentation and see if there's any difference in the responses.
All right, I'm going to give you 15 more seconds. This is not a final exam, guys. Don't worry about the grade. I just want to know what you think is the right answer. All right. So far, 57% have responded, 58, 60. For the rest, just pick any answers. It's okay. Okay, Dr. Chidis. So do we end it now?
Yeah, I think we can end voting and share the results.
Okay, let's do that and then see what people have put. All right. So for question one, 45% said all of the above. For question two, 75% said trigger and freeze. Question three, it's no real answer there. So about the same said lower OHSS versus same OHSS. Four, 50% said adding recombinant LH. Five, poor responders may benefit from. 54% said all of the above. And using REC-LH, so 60% said REC-LH will increase higher oocyte and embryo number. Okay. Very good. So let's see. Good. That's a good start. All right. So let's see how many will change their responses after the presentation. All right. So I'm going to start first with a case presentation for high responders. Okay. So MF is a 30-year-old black female, gravida 0, stopped oral contraceptives 3 months before initial consult and became amenorrheic. She had a history of irregular cycles before going on oral contraceptives. Her husband is azoospermic with Y chromosome microdeletion, specifically the B and C deletions, making this guy totally azoospermic. So if you go and do a testicular biopsy, you're not going to find any sperm. So in December 2014, when she presented, her BMI was 20. On ultrasound, the right ovarian volume was 7.15 cc, and the normal is about 3 to 4. Antral follicle count was over 40, and the left ovarian volume was 10.4 with an AFC of over 40 also. So classic polycystic ovaries. Her AMH was 32.3 nanogram per milliliter, extremely high. And as you know, anything above 3.5 is consistent with PCOS. Her LH was elevated, of course, compared to FSH. Prolactin was normal, estrogen was normal, thyroid function tests were normal. Her vitamin D was very low at 14.7. Her testosterone was elevated at 55 nanogram per milliliter. So I started her on a low-carb diet, vitamin D, inositol, and 3 weeks later, gradually increasing metformin up to 2 grams per day. Her AMH decreased within 3 months to 14.3 from 32.3. So started with the first cycle of tamoxifen and artificial insemination using donor sperm. The first month, she had a 15 millimeter follicle by day 14. She was triggered 2 days later, did not conceive. Second cycle, she had an 18 millimeter follicle by day 18, triggered, no pregnancy. The third cycle, she took 2 courses. So the first course had no response by day 16, did another course of tamoxifen. She developed a dominant follicle on day 31. And you can see how her response started changing totally over these 3 months. So I repeated her AMH and it came back at 50.4. This is the highest AMH I have ever seen. And her AFC, of course, was more than 30 per ovary. So what do you do for this patient? So let's start talking about high responders. First, definition. There's really no uniform definition. Some people use high peak estradiol of more than 6,000 picogram per milliliter and or high oocyte yield more than 30. When either is present, OHSS risk is 33%. When both are present, it's 80%. So if you look at Arce and Lamarca's paper from 2014, they define a high responder as anybody with an AMH above 5.2 nanogram per milliliter, which represented more than 70th percentile of the patient population they had in Europe. So an AMH cutoff, as I said, about 3.5 nanogram per milliliter has a 90% sensitivity and 81% specificity for predicting OHSS. An AFC of more than 30 obviously is a high risk factor. Young age, low BMI, and a previous history of OHSS. So this is from a paper by Andy Balin in Human Fertility from 2017. Again, basically a summary. Patient factors: young women, low BMI. Factors you found during the investigation: increased AMH, increased AFC level, and PCOS, of course, with hyperandrogenism and hyperinsulinemia. And factors during ovarian stimulation, if somebody responds with multiple follicles and high serum estradiol. So I'm going to take you back a little bit here. This is a paper I published in 1999 because in the literature there's this debate: do high responders have a poorer outcome in IVF than normal responders? So this is a paper from 1999 when we were doing day 3 transfers, which I think apply to many centers in India that do day 3 transfers. And in this paper, when we looked at estradiol levels less than 3,000 or more than 3,000, or whether we went by number of oocytes less than 15 or more than 15, we did not find any differences in pregnancy rate. But look at how many embryos we were transferring at the time. So this is a lot of embryos. I mean, now 90% what we do is single embryo transfer, and the rest is 2 embryos transferred. I have not done a 3 embryo transfer in few years. So at least back in 99, it showed that, you know, at least in our hands, we did not find much of a difference. But I have to point your attention that all of these patients that are high responders were on metformin or an insulin sensitizer for at least 4 to 6 weeks before doing this. So what about the experience with blastocyst transfer? So this is a oral presentation I had at ASRM. I have not written the paper. Actually, I should and add more numbers to it. But when we looked at peak estradiol, less than 3,000 versus 3,000 or more, what we found that the pregnancy rate was substantially higher. This is ongoing pregnancy rate, 81.3% in the high responders versus 69.4%, transferring 2 blastocysts in each group. And the multiple rate, however, was 50% and 42%. So again, no difference. If anything, high responders had a higher pregnancy rates compared to poor responders. What about if we look at the number of oocytes? We see the same thing. So when you get more than 15 oocytes, then obviously you transfer 2 embryos, the implantation rate was 62% versus 9%. The ongoing pregnancy rate was 81% versus 65%, and the twin rate was 52% versus 39%. So again, high responders have a better IVF outcome than normal responders. But you always have to worry about the risk of OHSS. But in this group, basically nobody developed severe OHSS. I may have tapped 2 patients in those more than 15, but this is not a common occurrence. So again, when you put both less than 2,500 picogram per milliliter peak E2 and less than 15 oocytes versus both, you will also see again a much higher implantation rate, 66% versus 51%, ongoing pregnancy rate 85% versus 68%, and multiple rate 55% versus 40%. So again, high responders actually do extremely well as long as you have changed their diet, put them on metformin beforehand. They will do extremely well. Now, what's the risk when you see high responders? Obviously, OHSS is the biggest risk. And you can see, and again, everyone knows Sunkara's data from the UK, that basically the pregnancy rates plateau between 15 and 20. So this is data from the SART registry in the US showing basically the same thing. Between 16 and 20 eggs is when it really plateaus. After that, it starts decreasing. And the risk of OHSS goes up significantly once you go above 20 eggs. Okay. So how do you manage these patients? So we recommend using the lowest possible starting dose of gonadotropins, 100 to 150. And, you know, obviously I understand in you know, whether in the US or India, this is a dose that we rarely even use. So we start slightly higher. This is basically European data, but somebody with very severe PCOS, you may want to start with about 150. It makes sense. There's no LH ceiling, but there's definitely an LH threshold. And the progesterone levels, because you're going to get a lot of eggs, you would expect that progesterone to be high. It does not mean that you need to freeze all just based on progesterone, because you saw from my data that the pregnancy rate is substantially higher. So the 1.5 nanogram per milliliter that everybody published on is really related more to the normal responder, not to the high responder or to the poor responders. The poor responders may be more sensitive at a lower dose of progesterone. So that's one of the answers to one of the questions that I had in the polls. GnRH antagonist protocols are associated with 50% reduction in OHSS compared to agonist protocols. So this is data from Denmark in 2016, and Menopur may even work better than recombinant FSH, which we've all been trained that this is not true. But I'm going to show you data that this is exactly what happens. So this is a paper that looked at both the MERIT trial and the MEGASET trials, and you're all very aware of this data. And if you put both together, so whether it's MERIT or in MEGASET or the pool data, you have a lower chance with Menopur at having women with more than 15 oocytes compared to recombinant FSH. So with Rec FSH, literally 51% had more than 15 oocytes versus 33% in the MERIT trial. In the MEGASET, it's practically exactly the same, 49% versus 31%. So the pooled data was 49% with Rec FSH and 32% with Menopur. So with Menopur, you have a lower chance at having these high responders. And also, if you look at the risk of OHSS or needing a paracentesis or albumin administration, it's substantially higher with Rec FSH compared with Menopur. Now, you say, okay, what we care about pregnancy rates. So this is what's going on with pregnancy rates. So in women with AMH level above 5.7, live birth rate are significantly higher with Menopur compared to Rec FSH. So this is the MERIT trial. You transfer, one embryo or the top quality embryo, you're going to find a pregnancy rate of 33% in Menopur compared to 20% with Rec FSH. In the antagonist, the MEGASET trial, it's 34% versus 23%. And the overall, you have a 12% decrease when you're using Rec FSH compared to Menopur in high responders. So again, it's counterintuitive or against things that you were told about before, but this is reality. This is two big published papers showing you this. Now, again, I'm talking about the progesterone a little bit. So this is data from 6 Organon or now, Merck trials, looking at the pregnancy with progesterone less than 1.5 versus 1.5. And they saw in the normal responders or the poor responders, when you have a high progesterone level, the pregnancy rate definitely diminishes compared with a progesterone less than 1.5. But in the high responders, there's absolutely no decrease when the progesterone increases above 1.5. Remember, you're going to have a lot of follicles, and these follicles are going to make a lot of progesterone. But there's also the estrogen level, which is critical. So what seems to be much more important is the estrogen to progesterone ratio and not just the progesterone by itself. So this is a study from one of the largest group in the US, actually the largest group at the US, called Shady Grove, where they looked at progesterone levels and put down the live birth rate as progesterone levels increase compared with cleavage stage transfer versus blastocyst transfer. And you can see that the pregnancy rates really start decreasing once the progesterone goes above 1.5. But even at more than 2, which I would assume is associated with high responders, there's a 20% live birth rate still when you do a fresh transfer. So again, across the board, doing a blastocyst transfer is associated with about double to triple the live birth rate compared to a cleavage stage transfer. So let's move on to GnRH agonist trigger. This has been obviously a big deal over the past few years. So GnRH triggers give you a short peak and area under the curve with significant alteration in corpus luteum function. And if you give a patient GnRH trigger, you're going to realize that they will get a period way before the 14 days that you would expect after you give them this. It depends on the dose that you give them. So the higher the dose of GnRH that you give them, the shorter that luteal phase is going to become. It nearly eliminates OHSS. It doesn't completely eliminate it. There's few case reports, at least 6, actually at least 20 that I know of, that developed OHSS with a GnRH agonist trigger. Now, at least these papers say they did not use any HCG, but when you use HCG along with the GnRH trigger, that's when the risk of OHSS increases. So if used in fresh cycles, you planning a transfer, you need to do aggressive luteal support, not just estradiol and progesterone. You really need to add 1500 of HCG like about every 3 days. But when you do this, then you worry about the risk of OHSS. So in the future, you may all have read about kisspeptin use, which is it's in clinical trials. The group from the UK has published a few papers on this. My gut feeling, when kisspeptin becomes economical, it's extremely expensive right now, it probably will replace GnRH agonist trigger. The way it works actually at the center on the hypothalamus rather than the pituitary. And as of now, I'm not aware of any OHSS cases with the use of kisspeptin. But again, the numbers are still relatively small. So adjuvant use, other than GnRH antagonist protocols, what do you do for these patients? So I believe that, as you all know, a lot of these PCOS patients have insulin resistance, even if they're thin. Actually, the thin PCOS patients are the hardest one to take care of. So these patients will surely benefit from an insulin sensitizer, especially metformin. But to give them metformin, and not the extended release form, it doesn't work. You have to give them the regular metformin. You have to change their diet. And in India, a lot of people are vegetarian, so they don't get enough protein. And if you talk to these patients, about 80% of their diet is actually carbohydrate based. And this is your recipe for not just diabetes and high blood pressure and heart disease down the road. You get very poor quality oocytes. So you really need to have them change their diet first and then slowly introduce metformin. And the final dose is going to depend obviously on the body weight of the patient. If they're overweight, I have gone as high as 3 grams per day. So albumin use, we can talk about this. I personally don't think it works. There's some paper on hydroxyl ethyl starch, which has decreased incidence of, which is given afterwards. Dopamine agonists definitely work. So especially cabergoline, you can give it to them, once a day for 8 straight days after egg retrieval or right before egg retrieval, and it will not diminish the pregnancy rates. VEGF growth factor blockers or leukotriene receptor antagonists are promising things, but right now they're in the lab, specifically using rat models. What about alternatives to traditional IVF? So you're afraid of somebody, you don't want to have them do IVF. You can talk to them about in vitro maturation. There's no randomized trials as far as I know, and the success rate when you do IVM is also lower compared to regular IVF. You can do mini IVF and you can do natural cycle, but there's no large trials, there's no comparative trial, there's poor evidence, and the success rate is very poor with natural cycles. So I'm going to go back to the case that I presented before. So what did I do for this patient? So she came in, and because of her very high AMH, I spoke to her about doing IVF with a freeze-all, not batch transfer, because this is somebody at very, very high risk at developing OHSS. So she wanted to do PGS also. She wanted to have a boy first. So I put her on birth control pill first. I used an antagonist protocol, and I started with 150 of urinary FSH and 75 IUs of Menopur. And by day 5, she has not responded that well. Again, this is a common thing you see with PCOS patients. So I upped her to 150 and 150. And she took a 9-day stim. She took 2,400 IUs total. Her peak E2 was nearly 3,500. Look at the progesterone. It's 3.0. That does not worry me that much. So I treated her with 2 milligrams of Lupron and 1,500 of HCG. That's in the early use of a GnRH agonist at that point. And I started her on cabergoline for 8 days. I got 35 eggs from her. So 3 days later, she called complaining of bloating with 5 pounds weight gain. So I brought her to the office. I did an ultrasound, and she had obviously fluid in the cul-de-sac. So she did not have any shortness of breath, and her abdomen did not seem really distended. But I tapped her, and I basically sucked out every single milliliter of fluid that she had. And I drained 2 liters from her. So that was a lot. 2 days later, her weight was back to normal, and she had absolutely no symptoms. She made 12 blastocysts that we biopsied and froze on day 5. 7 of these came back euploid. So we did a single embryo transfer in a frozen cycle, and she delivered a full-term boy. She came back in last summer. We thawed one of the other euploid embryos, and she actually delivered about a month ago or 2 months ago. So I'm going to switch gears here and talk about the pain of our existence. This is what we all complain of. It's not the high responders. The high responders now with GnRH antagonists, agonist triggers, we know how to manage them without having to worry about OHSS. The poor responders, there's really nothing much that works. So for us, it is one of the most frustrating problems that we face, and we face this on a daily basis. It is the #1 diagnosis in most urban centers in the US, what we call DOR, or diminished ovarian reserve. And economic downturns only make this worse. In the US, we had a big recession starting in 2008, and it went on till about 2012. And what we noticed, and this is a paper that was published in FNS in 2015, the incidence of diminished ovarian reserve increased from 19% to 26% between 2004 and 2011. And what we started seeing, which is we still see to this day, the mean age group of the patients coming to see me shifted by 2 years older. So it is real. And obviously it's a worsening global issue. Everywhere you go in the world, you see this problem. First of all, women are coming later to start families, okay? Maybe not as much as India, but definitely in Western societies. Even in India, nobody gets married at 15, 16 anymore. So aging, pollution, smoking, surgery, all these type of things. And there's definitely ethnic variations in the US and other parts of the world. China and India are definitely cases. And I was telling Dr. Chittis before that I published a paper back in 2012, and the EV group published a study from their center in Abu Dhabi in the UAE, where they showed that there is an age difference of anywhere between 4 and 6 years between Caucasians and Indians. So the Chinese may even be worse. And like I said, in the paper I published in 2012, my Indian patients were 4 years younger, and they had similar outcome to Caucasians. So when I see a 38 or a 40-year-old Indian coming to see me, I know without doing any tests at that point that they have diminished ovarian reserve. So compared to whites, they're about easily 4 years older from an ovarian point of view. So how do we define? So I'm gonna start with the case presentation again here. So this is a 29-year-old Nigerian female, probably the only 29-year-old that I saw in my practice that year. But look at her story. Long history of endometriosis. She's had laparoscopies with bilateral ovarian cystectomies. And now as a tangent in here, the treatment for endometriomas is to leave them alone. The worst thing you can do is to go and do ovarian cystectomies on them, because you will cause that patient to become a diminished ovarian reserve patient. Unless, of course, you're talking about somebody who has a 7 or 8 centimeter endometrioma at that point. So she had also a left salpingectomy. She was treated with Depolupron for 6 months which is depo-GnRH agonist. She failed 2 IVF cycles elsewhere. The first cycle, she had no eggs. The second cycle, she had 3 follicles, also no eggs, and she was told to do donor egg. So she went to Nigeria and did a cycle in Nigeria. They did a Ganirelix protocol with Clomid and 300 IUs of FSH and 300 IUs of HPHMG, of Menopur. So that's 600 IUs, and that is a very high dose, which we don't use. So they got 5 eggs from her. They transferred 2 blastocysts. She did not get pregnant. So when she came to see me, I did an HSG on her, and she sure enough had a right hydrosalpinx. She had a 3.5 centimeter left endometrioma, and she had a right hydrosalpinx. Her FSH was already high at 15.4, and her AMH was low at 0.94. Her enteral follicle count was 6. So I saw her on DHEA and CoQ10, and her thrombophilia profile showed elevated anticardiolipin antibody IgM. She was sent to a gynecologist who did a right salpingectomy, but she also did a left ovarian cystectomy despite being told not to do it. So how do you manage this patient? So let's go over some definitions first. How do we define a poor responder in the US? Most of the times we use AMH as less than 1, even less than 0.7. An enteral follicle count of 5 or less, peak estradiol of 500 or less in a prior cycle, less than 4 or less oocytes in a prior cycle, or prior cycle cancellation in poor response with high gonadotropin dose. High meaning anything above 300 IUs per day. Not just women over 40, okay? So the European have this Bologna criteria, which we don't use in the US, okay? So the Europeans like to make their lives very complicated. We like to make things simple. So in the Bologna criteria, if somebody is 40 or older, even if they have PCOS-like ovaries, they're poor responder by Bologna criteria. That made no sense. We understand that by abnormal ovarian reserve between less than 5 to 7, an AMH of 0.5 to 1.1. This is a huge range, okay? So 1.1 in my practice is a normal responder. A 0.5 is definitely a poor responder. Other definitions, if they did a prior cycle with less than 3 oocytes or less with conventional stimulation, or 2 episodes of poor ovarian response after maximum stimulation. So that Bologna criteria didn't go too far. So in 2016, the Europeans came again with something called the Poseidon criteria, which is patient-oriented strategies encompassing individualized oocyte number. Again, where do they come up with these acronyms? I don't know. But they made things even more complex. So now we have Poseidon group 1, 2, 3, and 4. And in group 1, there's subgroup 1A and 1B. And in 2, there's 2A and 2B. So again, this is a revised Bologna criteria that I don't think anyone in the world is going to really follow these. So does anything help? More importantly, we know how to define poor responders. How can we help them? Okay. So does increasing gonadotropin dose help? Does the REC-LH addition help? Does CoQ10 addition help? What about androgens, DHEA or testosterone? What about growth hormone? What about freeze-all and embryo banking and PGS? So I'm going to talk about each one of these. So I'm glad so many people are listening tonight. But this paper was published in December 2015. It totally finished the discussion about whether you should go above 450 IUs in poor responders. The bottom line, you should never go above 450 once you're stimulating a poor responders. There's some data that actually the higher you go, the worse these eggs are going to look like. Okay, so there are people in the field that actually say even 300 IUs is the maximum dose you should use. But in my practice, I have never gone above 450, and I hope moving forward for all of you, you do not either. So what about the addition of recombinant LH? So I've seen from the poll answers that a lot of you believe that adding REC-LH to the stimulation changes outcome. And I'm sorry to tell you that the summary answer, it does not do anything. So this is the SPAR trial, which is the efficacy and safety of Pergoveris, and as you know, Pergoveris is REC-FSH plus REC-LH in ART. This study was published in the January issue of Human Reproduction in 2017. So this data you should have heard by now. But this is a trial on Bologna criteria defined poor responders. And sorry, they split them into a REC-FSH plus REC-LH arm at a 2-to-1 ratio. So if you start somebody at 450, there's 300 of FSH and 150 of REC-LH. The maximum dose is 450 of FSH and 225 of LH versus REC-FSH alone. Okay. Now, what did the results show? So if you look at the number of oocytes, when you add REC-LH compared to FSH, there's absolutely zero difference, none whatsoever. You do not get a single oocyte more. The median is 3 in the REC-FSH, and it's 3 in the Pergoveris arm versus the REC-FSH. 3 and 3, absolutely nothing. And this is a large study, 462 patients that were part of this study. Okay. So what about outcome? Okay, so maybe the oocyte is a little bit better. Absolutely no difference. Biochemical pregnancy was the same. Ongoing pregnancy was the same. Delivery, live birth rate was 10 versus 11. And then mean number of oocytes was the same as I showed. So those, obviously, for FSH is the same because the only thing you're adding is extra LH, which does not do anything. Why doesn't really work? So the half-life of LH versus REC-LH are exactly the same. So which is 1.44 hours for endogenous LH and 1.35 hours for REC-LH. It's gone from your system in no time. And this is the studies that showed absolutely no difference. But that study was actually sponsored by Serono to try to see if REC-LH makes a difference, and it doesn't do anything. So that's your answer to one of the poll questions. What about CoQ10? So there is no real comparative data. This is, I picked just one paper to show you that in mice, actually, when you add CoQ10, you will have better chromosomal alignment and less spindle defects in the mouse embryos, whether young or old mice, when you add CoQ10. Do I use it in my practice? Yes. Do I believe it makes a difference? If you look at the mouse data, you need to put somebody on CoQ10 for about 2 years to see a response. So I would recommend, when I see a patient who's a poor responder coming in to see me, from that day, actually at the initial consult, I tell them to start taking CoQ10. Again, 1, I don't believe it harm. 2, it may help by the time we do an IVF cycle. What about DHEA? So there is more and more data right now that adding DHEA helps. So this is a review paper I published back in 2013, and since then there have a few other studies. This is the, as of 2017, this is the whole literature on DHEA. But most importantly, if you look at the Cochrane review, which was published in 2015, so it showed that using both DHEA and testosterone is associated with a higher pregnancy rate, and that's a moderate effect, and it decreases miscarriage rates. It doesn't do anything to the multiples, but both DHEA and testosterone are associated with improved response in poor responders. What about growth hormone? So that's a paper I published in JCNM back in 1994. That was my fellowship thesis. So I discovered the growth hormone receptor in the ovary. Up to that point, nobody knew how growth hormone really worked. They thought it worked through the IGF-1 system. It actually worked through the growth hormone receptor system and through IGF-1. And if you look where the receptor is, it's in granulosa cells, but not in theca cells. Again, granulosa, but not in theca. And you don't see growth hormone receptors in eggs. You see them in corpora lutea. So we know the growth hormone receptor works on, the growth hormone works on its own receptor. And that's how it works. So this is a review paper that was published in 2017 in Medicine by Lee et al., where you look at how growth hormone really helps. So it helps by increasing oocyte number, increasing M2 oocytes number, increase pregnancy rate, and decrease gonadotropin dose. But most of these studies are really small studies. And I know Rob Norman in Australia tried to do a randomized trial a couple of years ago that he presented at the Australian Fertility Society meeting. And he was having a very hard time recruiting because patients all wanted to take growth hormone. They did not want to be randomized to the group that was the placebo group. And again, this is data from the same thing showing that increased better outcome with growth hormone. Now, when is it the best time to give it? Do you give it in the preceding luteal phase before or during stimulation? First of all, it's very active, at least in the US. And number two, at least through the small numbers that were published in that the Lee paper, it looks like when you give it during ovarian stimulation, it works better than giving it during the prior luteal phase. And again, the cost is the biggest barrier right now. What about embryo banking? So in these poor responders that may make 1 or 2 eggs and maybe one blastocyst, doing embryo banking makes sense. So you can bring them in and do multiple cycles. And once you have enough banked embryos, you can do PGS at that point and then do a transfer. And this is what used to be called the Shanghai Protocol. So you basically put them on Clomid or letrozole, you give them FSH or HMG, and basically you trigger them. And a week later, after egg retrieval, you actually start another cycle. So because oocytes grow in waves, so you can basically get them immediately to do another cycle. Even if you have a corpus luteum, you don't need to worry about this. But I personally have never tried this because I always want to try to get as many eggs from both ovaries as I can. And this is a recent paper published from Turkey showing that the optimal strategy for poor responder may include not doing a fresh transfer, but doing a freeze even without PGS, and then doing a frozen embryo transfer. And I'm going to end with a couple of slides right here about something called the intrinsic fertility of human oocytes. As you all know, Japan is a leader in what's called the natural cycle. There's very few centers in the US, and I assume in India, that do natural cycle because the outcome is really extremely poor. But if you basically go in and retrieve eggs and do a single embryo transfer, now again, up to 50% of the times you're not going to have a blastocyst to transfer. But if you do have one, what are the success rates if you do a single embryo transfer from that single egg? So if you're young, it's not bad. It's about 26% success rate. But look what happens as women start aging. So by 35, you're at 24. By 36, you're at 21. By 37, you're at 19. By 40, you're at 9%. By 41, you're at 6%. And by 42, you're at 4%. And when you go beyond 42, basically it's 1%. So if you go and see this from a schematic format, this is the live birth rate, the older you get, and then you have this free fall starting around 37. And by the time basically get to about 42, 43, it's basically zero. Okay, so if you see a patient coming in and she's 47 years old and she tells you, I still want to try with my own eggs, you can tell her her odds are basically zero at that age. So going back to the case presentation, what did she do? So the first cycle was in April 2016. Her AFC was 7, so I did a luteal protocol with 6 menopure and growth hormone for her. She did a 10-day stim. Peak E2 was 638. Peak progesterone was 1.35. She made 3 eggs. 3 were mature, 3 fertilized. She made 2 BB blasts. So I transferred this. She got pregnant, but at 32 weeks, when she was in Nigeria, when she went back to Nigeria, she had a stillborn, and we really don't know what happened over there. The autopsy was a perfectly normal baby. So yeah, she was in Nigeria until 3 days before she came to see her OB and they did not see a heartbeat. So what happened over there, no one really knows. And she was on low molecular weight heparin for that positive ACA. So she came back in March of 2017. Her AMH was undetectable at that point. Her FSH was 13, her AFC was 3. So I did the same protocol with her. She made 1 egg, and this was my only day 3 transfer over the past 7 years. And because she said, you know, it's might as well just put it back, and she did not get pregnant. So she came back for a 3rd cycle in August of 2017. Same protocol. Luteal Lupron, 6 Menopur, growth hormone, peak E2 384, progesterone 0.31. She made 5 eggs, 3 mature, 3 fertilized, 2 embryos were transferred, and she has an ongoing twin pregnancy right now. She is, I think, 30 or 32 weeks right now, and she has a boy and a girl. So now I'm going to go back to the survey again. Dr. Shittis, can you help me just put the new survey again? So we'll start from scratch, and because I want to see if your answers are going to change after that presentation.
Can you see the new survey now?
Yeah, I do. It's not so I would love everyone to go back and start answering these questions all over. So again, 1, effective strategies to decrease hyperresponse include the following: A, insulin sensitizer pretreatment; B, dopamine agonist use; C, GnRH antagonist protocol; D, HPHMZ use; and E, all of the above. The second question: when faced with a patient at high risk of OHSS in a GnRH antagonist cycle, what do you do? Trigger with H, cancel the cycle; trigger with agonist and freeze all; trigger with an agonist and transfer. The third question: the use of Menopur in high responder is associated with higher OHSS risk, same OHSS risk, lower OHSS risk. And then proven strategies in poor responders include the following: increasing gonadotropin use, using GnRH antagonist protocol compared to agonist, adding REC-LH, androgen pretreatment, DHEA, and testosterone. And poor responders may benefit from 2 to 3 months of ENDS, addition of growth hormone, maximizing gonadotropin dose at 450, embryo banking, and then all of the above. And the last question: using REC-LH in addition to REC-FSH in poor responders compared to REC-FSH only is associated with higher oocyte and embryo number, same oocyte and embryo number, lower oocyte and embryo number. And please start the poll. Dr. Chittis, I can't see the poll data. I see the questions, but I can't see the poll like I saw it when we started.
It's coming on my screen, so once everything is done, I'll end the poll. Good. And share the results.
Okay, excellent. At least you can see the answers coming in.
Yes. Up till now, 52% people have voted.
Excellent.
I would urge everyone to just put in answers for all the questions, and then you have to press the send vote button. There's a send vote button at the end, bottom. So just click on that so that your answers get registered in the system.
Yeah, hopefully we'll get a totally different answer profile than the pre-lecture. In some of the questions, at least. How many have voted so far?
60%. So I'll end the vote and share the results now.
Okay. All right, so let's go over the answers. So the first one, effective strategies, the correct answer is all of the above. So 61% did that. Everyone will decrease the chance of hyperresponse. When failed with a patient with high, 73% had the correct answer. So that's very good. That's what I would do. The third one, the use of HEMG is definitely associated with lower HSS risk. So after the lecture, only 56% got this. 100% should have gotten this one, but that's okay. Proven strategies and response includes exactly right. So D is the correct answer. Androgen pretreatment, none of the others have been proven to make a difference. And I presented this data. So none, A, B, C are all wrong answers. And 5, all of the above is the correct answer. 61% got it right. And number 6, so despite my lecture, only 50% were paying attention. So it is the same. So B is the correct answer. So
That's
it does not
out of 70% who voted, 52 have voted in your favor.
Yeah, right. Okay, very good. So not bad at all. So now I'm going to open the floor for questions, and please ask any questions. It doesn't need to be necessarily related to the talk. Obviously, ideally, it's any questions about high responders or poor responders or anything you may have. I'm all yours. And don't be shy. I can't see you, so you can submit any question.
Dr. Paddy,
So
can you?
Dr. Dis,
Yeah.
no, where are they? Where can I see the questions?
Oh, okay. It's in the chat window, the main chat. You
Chat.
can click on the main chat.
Chat
Lower left.
window. Yeah, okay. So I'll go to the main chat. Okay. Okay, now they're starting to come. Very good.
Yeah, bottom 5. Yeah.
Okay. Okay, excellent. So so the first question, actually, Dr. Neg is asking, is there a role of adding dexamethasone during ovarian stimulation in PCOS? That's an excellent question. I personally do use it. So I put all of them, I give them dexamethasone at 0.5 milligrams during the stimulation phase. So is there data on this? The short answer is no. What is the main reason why I give them this? I would like to keep the progesterone level the lowest possible, because as you know, progesterone is not being produced just by the ovary, it's being produced by the adrenals. So by giving the 0.5, I hope to at least make the contribution of the adrenal the lowest possible. So I agree with you. Dr. Singh asked, what is the dose of growth hormone in poor responders? I use 4 IUs per day. So this is, if you look at the whole literature, there is no uniform dose. But because growth hormone is so expensive, I try to limit it to just 4 IUs per day, and it has worked great in my hands. So that's the dose I use. The third question is, how long should we give CoQ10 for poor responders? Excellent question. I actually keep them on it. So even, while they're pregnant, at least the early phase, even if they want to stay on it during the pregnancy, it's not going to harm. Remember, it's CoQ10, so it's an antioxidant. So for me, I just keep them on it. I start with 400 milligrams twice a day. Rarely I've gone to 1200 milligrams per day, but the lowest dose should be 400 milligrams twice a day. What is the ideal E2 to P4 ratio? There's no published ideal levels. I look at the number of follicles, the number of oocytes, and the E2 and P4 before making a decision whether I should freeze or not freeze. So the vast majority of the times, if I have a poor responder that makes 3 eggs and their progesterone is 1.5 or 1.4, that's somebody I would rather freeze rather than do a fresh transfer. If you look at Vanetis's review of over 60,000 cycles, there's actually a figure that shows you what the cutoff progesterone is for poor responder versus normal responder versus high responder. And the poor responder seems to become affected at a progesterone above 1.2. For normal responders up to 1.5. For high responders, you can easily go to 1.8, even 2, without even worrying. So that paper was published a few years ago. I would highly recommend you go and review it. With low dose stimulation, does duration increase and oocyte deteriorate? Absolutely not. So unless you're giving them a dose that's so low that they're not going to do anything, or they're going to do 1 to 2 oocytes. So you need to, the way I decide on the dose to start, I look at everything. I look at the patient's age, BMI, ovarian reserve, and if obviously prior cycle if they have gone through a prior cycle. But somebody who is thin, you know, a BMI of 24 with normal AMH and normal AFC, you can start at 225 and gradually go down if need be. If a poor responder, it's maximum dose. So I use a lot of Menopur, so you can go 450 I use of Menopur. Sorry. Or if you like to mix, you can give 225 of Rec FSH and 225 of Menopur. And there is data back from 2004 that actually the best ratio, if you want to split and use FSH and HMG, is to use them at the 1-to-1 ratio from day one. So if you want to use 600, you should, not say 450, you should use 225 of Rec FSH and 225 of Menopur. At least this is what I do. What is the experience about elective cryopreservation for a subsequent frozen embryo transfer? So around the world, more and more people are doing freeze-alls, which I completely disagree with. And if you've seen, there were 2 papers in the New England Journal of Medicine last month, one from Vietnam, one from China, that showed absolutely no difference between freeze-all versus doing a transfer. And doing a freeze-all is going to cost people more money. So in PCOS ones, the Chinese group also showed no difference, except they had a lot of people lose their pregnancies in the 2nd trimester. And I'm really worried that these actually were terminations of female babies. It doesn't say this, and ask the author that question at last ASRM, and she was very shifty in answering my question. So, but now we have 3 papers in the literature, even one with PCOS and one with normal responders, showing no difference in ongoing pregnancy rates between freeze-all versus fresh transfer. So my advice to you is, unless your progesterone level is extremely high or there's a patient at risk of OHSS, I would still do a fresh transfer. Let's see here. How do you use growth hormone? I already said it. Is there any minimum and dose of duration of Coquinel? We spoke. What is the lowest level of AMH or AFC where you counsel for donor egg? Okay, excellent question. There is no real answer for this. So unless somebody has an FSH level of 20 or above and undetectable AMH, and you do an AFC and they have 0 or 1, those patients go straight on donor egg. If I can see 2 or 3 eggs in a young patient, I will actually take them. If you have a 44-year-old coming in with that picture, she's not going to even make a blastocyst. So, but many programs are leery about telling patients, no way, I will try. As long as they have some ovarian reserve and they're young, I would tell you, go with this. But again, you have to look at the whole picture. Somebody 42 or above, an FSH of 18, an AMH that's undetectable, and an AFC of 2, I will counsel this patient to do donor egg for sure. Role of myo-inositol, excellent question. I use it routinely in my PCOS patients, along with metformin. So there's few papers in the literature at this point, nothing large scale, that showed the importance of not just myo-inositol. There's data on something called resveratrol, and definitely adding vitamin D. So I measure vitamin D on all my patients, and the lowest values I see are in my Indian patients. So those need to go on high doses of vitamin D. There's a meta-analysis that was published a couple of months ago in Human Reproduction, looking at the association of vitamin D with pregnancy rates, and they quoted one of my presentations, and we showed actually that if the vitamin D is low on the day of egg retrieval, their pregnancy rate is lower than those people who have a normal vitamin D. So that's another thing I would definitely add for. The other question, Gupta, you talked about embryo bank and PGS subsequently. Does that mean we need to freeze each and then thaw and biopsy and then freeze until result? But won't repeat freezing and thawing affect quality? So what we do in here, we every time actually, if we're doing banking, we don't just, so I biopsy and then freeze. So if you're planning on doing PGS, you should biopsy and freeze. If you're not planning on doing PGS, you just freeze. So I completely agree with you, Dr. Gupta. We don't like to freeze and thaw and freeze and thaw. So that's why we counsel our patients to do the biopsy when the embryo is still fresh and then freeze it. Again, you know, if the embryo is genetically abnormal and poor quality, it's very likely this embryo is genetically abnormal. But I'm completely in agreement with you. I would rather do the biopsy and then freeze rather than freeze and then thaw and then. But there are programs who do it because of cost. In what condition recombinant LH is considered? Zero. There's no condition where I would use recombinant LH. I just showed you at least the SPAR trial. So, and I reviewed the data on Rec LH recently. There is no condition where it helps. At least this is what has been published. Forget what the rep tells you. I'm talking about scientific facts. Any role of PRP injection for diminished ovarian reserve? So this is platelet rich or plasma rich platelet. I'm not aware of any data that showed. There's a group in the US trying to do this. They have not done a single transfer. Okay, so this is to me quite invasive because you have to go and inject these in the oocytes. So I would say at this point there is no role until you see randomized trials showing an improvement. The last thing you want is to do this on a patient who's going to get infected, septic, and die. So at this point, I caution you not to do it unless more data comes up. It's not benign. The other question, what is your observation about AMH level in hypo-hypo? Excellent question. A hypo-hypo patient is going to have very low AMH because, you know, there's these, whatever follicles they have are basically in suspended animation. In the very few patients that I've seen that have hypo-hypo, it's not a common thing. The AMH is usually extremely low. So I would not put too much stock in the AMH level in hypo-hypo, okay? Unless, you know, obviously somebody is old and you do an AFC and they have very few follicles in there. Please repeat the stimulation protocol where you give that Nigerian female. So it's a luteal lupron, so no pill, let her ovulate, day 21, you start on a GnRH agonist, and then when she gets her period and you start stim, it was 450 IUs of Menopur along with 4 IUs of growth hormone every day during the stimulation phase. Which route is better for androgens, oral or transdermal, any difference? Okay, the only way I have ever used it, and I've been using this for years, I've only used the HEA, I have used transdermal testosterone. As far as I know, there has not been a single comparative study between DHEA versus transdermal testosterone. Both work, okay? It's which one you have more experience with and which one you feel more comfortable with. So Dr. Singh, again, in case of PCOS, you need REC-FSH 150 and 75 of HMG. Should we use HMG in combination with the REC-FSH or HMG alone? I always add, if I don't use only HMG, I always add HMG. So 150 of REC-FSH and 75 of HMG works, or 225 of HMG work also. So anything works as long as you're adding some HMG. And you know, you're all aware of the data that showed in every single study that compared Menopur with REC-FSH, the progesterone level is lower with Menopur compared to REC-FSH. So if you're planning a fresh transfer on that patient and using a HMG, more HMG actually makes sense. In the US, we did a trial here called Megaset HR. with, the data is being analyzed at this point, but they present some of the data at ASRM in October that showed that there is a lower chance of AHSS again when using Menopur and high responder, and that progesterone level were substantially lower compared to REC FSH. So again, if you're planning on a transfer, definitely add HMG or go all HMG. If you do fresh transfer with agonist trigger, do you always support with HCG? Yes. So the early data, Peter Plateau's, not Peter Plateau, but the guy in Denmark, I'm blanking on his name right now. But when they used only agonist triggers, their pregnancy rate was horrible. So they came up with this to salvage it. Even when you give them very aggressive estrogen and progesterone support, these corpora lutea are so bad that you really need some HCG to pick them up. So I give them 1500 along with trigger, and then 1500 2 times, and then that should be it. But I personally rarely do a fresh transfer when I use a GnRH trigger. Part of the reason in the US we're doing so much PGS at this point because our patient population is much older. Which fruit or progesterone you use for luteal support? Okay, so there's a paper that just came out in the February issue of FNS that you absolutely have to read. This puts the debate, unfortunately, to bed. So this is a large study. When they did the interim analysis, they had about 650 patients, and they did 3 arms. The first arm was vaginal progesterone only. The second was vaginal progesterone plus IM progesterone, 50 milligrams every 3 days, and the third arm was IM progesterone only. But this is in a frozen embryo transfer. So if you do a fresh transfer, you can give IM progesterone or vaginal. Okay, that there is no real difference. If you look at the published literature, there is no difference when you're doing a fresh cycle. Okay, but when you're doing a frozen embryo transfer, you have to use IM progesterone every 3 days or IM progesterone only when you're doing FET. So this is, at least when you're doing a frozen embryo transfer, you can use vaginal and use endometrium, but you have to add 50 milligrams of progesterone every 3 days, and the pregnancy rate is fine. If you use only vaginal in a frozen embryo transfer, the ongoing pregnancy rate is 50% lower. So that's a paper I highly recommend you read it. If you have to decide for freeze all, what? And then there's no, I don't know what the rest of the question is. So let's move to the next question. Addition of GnRH agonist 6 days after PU. Okay, that's an excellent question. There's some data, especially the Testard, I think the French guy that published on this. Right now, the papers that have been published, and they're very few, show that actually it can increase pregnancy rates. I personally have not used it, but there's few papers that have shown that it may help in poor responders. Dose of vitamin D depends on the level of the vitamin D in the patient. So if you have somebody with a vitamin D of 5, then you have to give them 50,000 IUs per week for at least a couple of months, and then probably 5,000 a day until you get there. If you have somebody at 20, I would give them 5,000 a day. What's the ideal vitamin D level I would like them to get at? Above 45. That's the ideal. So there's few papers. There's one paper in the OI-IUI literature that was published from the US when they looked at who got pregnant and who didn't. Having a vitamin D above 45 seems to be a cutoff. Dose of vitamin D, same thing. Which protocol is best for diminished ovarian reserve? Antagonist or long luteal lupron? That's an excellent question. I have looked at both. I have seen that using a long lupron works better than using an antagonist protocol. One of the things I always worry about is with antagonist, especially if you're using very high FSH dose, your progesterone level is going to go higher. So with a long lupron, it's going to keep the progesterone level at the lowest level, and definitely add dexamethasone with this. But my protocol of choice for responders is actually a long luteal lupron. How do you use testosterone dose time route? I would urge you to go review the literature. It's a transdermal route, but that's all I can tell you. And I think you need to change it quite often. If you have to freeze all, would you consider most it's E2 or progesterone level or no? If you're doing a freeze all, I mean, I always look at these levels, okay, regardless whether I'm doing PGS case or not. So I would like to know what levels are. There's absolutely, even if you have a cycle with high progesterone level, when you're doing a frozen protocol, it's not affected in any way, shape, or form. But your progesterone level is going to depend on your aggressiveness of stimulation. Again, with the estradiol. Can you postpone ovarian aging by using Mirena? I absolutely have no data, and I doubt very much, Dr. Kumar, you can postpone ovarian aging. Women age at different speeds, and that has to do with genetic makeup. Unfortunately, in India, you guys have patients who go into diminished ovarian reserve at a much faster pace. But I am not aware of any data when you're doing this. And remember, when you do an IUD, it's practically the effect is solely or mostly on the endometrium. I personally don't think it will affect the ovary in any way, shape, or form. The only way you can postpone ovarian aging is if you plan on having a lot of children. So there's a paper that was published in FNS at least 15-20 years ago from Israel where there's a type that basically does not even contraception. They have children, they get married at 15 and have children. So these women can still have children well into their 50s because they never get periods. They're either pregnant or breastfeeding. So that's the only indication or the only observation in the literature that I'm aware of where you can postpone ovarian aging. But I doubt very much any woman wants to have 23 children, or at least any sane woman. So that's a different story. So if REC-LH has no role, then what's the point of adding HMG? Excellent question. What does HMG or specifically Menopur has? It has HCG in it. And HCG's half-life is 36 hours. So I measure HCG levels during ovarian stimulation when I'm using Menopur, and it is detectable as early as day 5 of stimulation. So this is the reason why you use Menopur with your FSH or Menopur by itself. It's not the LH, it's the HCG. If you're using generic HMG, I completely agree with you. There may be not that much of a difference between this. But there are some cases, some PCOS cases that have high LH radioactive like levels, but very low H bioavailability. So these are the cases where they do better with HMG. But the difference in Menopur is in its HCG content. There's no LH in Menopur, but that's an excellent question. So pre-treatment with which is better, estradiol or I would assume that's OCP or progesterone antagonist protocol. When I'm using an antagonist protocol, I always put patients on the pill. I don't want to flare a previous corpus luteum. Not only that, I want uniformity of growth of these follicles when they grow. That's another reason why I like the long luteal protocol in poor responders, because poor responders have the highest chance at having one follicle grow and the rest just not do anything or be really behind. So that's an excellent question too. Ovarian stem cells improving AFC and quality of oocytes in poor responders. Okay, excellent question. Right now, company in the US that's based in the US that is doing this, and it's called Ova Sciences, is nearly bankrupt. There has been some trials going on, not in the US because the FDA would not give them approval to do trials in the US. Right now, it's very, very iffy whether anything works or not. So this is Jonathan Tilley's data. There other stem cells that the Japanese and the Chinese are currently working on. They have made oocytes, not precursors, but oocytes by adding some precursor cells. But right now, I would not use it clinically at all. One, it's extremely expensive, right? Number two, it has really not proven to work. Any role of serum testosterone measurement before adding the HEA? I actually do, and I measure it in my patients that taken the DHEA, and the testosterone levels do increase, and that tells me that the patient is taking the DHEA. So I measure DHEA, DHEAS, and testosterone. Remember, DHEA's half-life is very, very quick, so you may not see the DHEA being elevated, but your DHEAS and your testosterone levels will be higher when you give them DHEA. Excellent question. If there is only one good quality embryo and one poor quality embryo, do you recommend transferring only the good quality or both embryos? Does that transfer hinder this? So this is a fantastic question. There's some data that it may. So depending on what a poor embryo quality is, if you have an embryo that's basically a 4-cell and completely fragmented, I would not transfer it on day 3. If I have a nice blastocyst and the blastocyst that's a grade C, we never transfer a C. A BB is the maximum we would transfer. A BB can lead to a pregnancy in about 30% of the times, and an AA or an AA blast in our hands gives us a single embryo transfer live birth rate of 70%. If it's an AB or BA, it's about 50%. So if you have an embryo that is really poor, I would not transfer it. This embryo is not going to make it. And I don't believe in these people tell you, oh, this is a C grade blastocyst, unless that's the only embryo they have, and you can at that point transfer it, but very rarely you're going to get any pregnancies. So my recommendation would be transfer the good quality embryo and not poor quality embryo. Again, it all depends how you define poor quality. So even if we supplement progesterone, do we have a low progesterone rate? Why do we have low progesterone rate and agonist trigger compared to HCG trigger? Of course, when you give an HCG trigger, that corpus luteum is completely dysfunctional at this point. You're killing these corpora lutea. That's why the progesterone level is so poor. Not just the progesterone level, the estradiol level is so poor. That's why the recommendation when you trigger, unless you add HCG, is do not transfer. Freeze and then do a frozen transfer. How many days of minimum days of estradiol or how many maximum days of estradiol exposure recommended for starting injection? Okay, that's in a frozen cycle. So the minimum is 10 days. I would like to get to about 14 days before starting progesterone. But the minimum should 10 days of progesterone. And you have to look at the endometrial thickness. And obviously we would like to see the thicker the better. But if somebody has an endometrial thickness of less than 7 millimeters and at day 14, then add another week of estrogen and see what happens. You can switch it to vaginal. Unless this patient has thin endometrium. And in that case, I published a paper 3-4 months ago in Journal of Assisted Reproduction and Technologies telling you how to treat these thin lining. This is a very frustrating problem. Your take on luteal phase stimulation. Okay, excellent question. That's partly what I address a little bit in this Shanghai stimulation. You can definitely do this. Especially I would assume you're planning on doing a freeze all in that cycle. Otherwise, I would not. So you can only do it in the context of freezing everything. Any role of estrogen from day 21 in cycle prior to stimulation for poor responders? Yes. I have done these estradiol priming cycles before. Some people believe in them. I have tried them and stopped doing them, at least 2-3 years ago. But that's instead of using the pill. If you're planning on using an antagonist cycle, that's another way you can do it. So you can give them estradiol 2 milligrams orally twice a day, starting on day 21, and then when they get a period, bring them in and do an ultrasound. So this is a way to actually cause a homogeneous follicular pool before stimulation. So yes, you can definitely do this. Some patients have large stroma. Notice when doing surgery. These are your PCOS patients. These are the patients who are who have high androgens. That's what the stroma secretes. Some says you have to add LH if large stroma. So it all depends. In these cases, again, I feel more comfortable stimulating them with Menopur rather than with RAC-FSH. These patients are at very high risk of ovarian hyperstimulation also. When I see this thick stroma, I do not take somebody to an IVF cycle for at least 2 to 3 months. These are the patients you need to put them on inositol, on vitamin D, on resveratrol, and on metformin. before you do IVF on them. Otherwise, your failure rate is going to be pretty high. With OCP treatment, do you wait for menses after stop pills? Yeah, of course you do, unless they've been spotting all along. So I bring them in, if they don't have a period, I bring them in, a couple of days before planned stimulation start. If their ovaries are quiet and their lining is thin, then I can get started regardless of menses. But if their lining is thick, I definitely do not start them. Okay, this is somebody you need to wait until they have menses. Time is short, no more questions. Okay, so I'm gonna end with maybe the last 3 questions right here. It's already on estrogen. Yes, you can. You can definitely try this. That's again in poor responders, one thing you can try. Experience on day 3 versus blast transfer. We don't do day 3 transfers. We have been basically since 2003. We have been an 80% blast transfer, and in 2011, since 2011, we have done just one case of transfer that I presented. Other than this, we're 100% blastocyst program. Cause of granulation of oocytes, can we prevent it? No, this is poor egg quality. Cloning of oocytes, you're going to have to wait, Dr. Kumar, a little bit. This is what the Japanese and the Chinese are working on. There's some encouraging data in a mouse model. I don't see this coming to human trials for years. And remember, mice are not women. So the ovary is in women is a much more complex. We use blastocysts from mice to do our QA, and I'm sure you do the same thing. And in mice you can nearly grow blastocysts in water, nearly. So this is very unlikely in women anytime soon. Which trigger is better, agonist or HCG? It all depends what you're doing, Dr. Adil. If you're planning on doing a fresh transfer, I would definitely use HCG. If you have somebody who is worried, you're worried about OHSS, then I would give them an agonist trigger and freeze. But for me, if I'm planning on a fresh transfer, it's always HCG.
Okay. Can you hear me, everybody? Can you hear Dr. Fadi?
Yes, I can.
Yeah, Dr. Fadi, thank you so much for the excellent presentation. We had almost more than 50 questions, and you've been kind enough to answer each and every one of them. I would like to call upon Dr. Amol from Ferring to give the closing remarks and thank Dr. Fadi on our behalf also.
Hello.
Thank you all for the great questions.
Can you hear me, everyone? Hello?
Yes.
Yeah, so hello, myself Dr. Amol Patel from Ferring, and first of all, I would like to thank you, Dr. Fadi, for this really energetic presentation. I would say that at the end of it, it was a rapid fire of questions, like it happens in a quiz, a rapid fire of questions, and you were just unabated going on answering each of them, giving due justice to each of the questions. So really thank you, Dr. Fadi, for taking out the time and giving out this presentation on a very critical topic of high and poor responders. And I think you have given your insights on nearly each of the aspects where there is still lack of clarity on many aspects of poor and high responders. So we thank you so much, and I would just like to say that your years of experience and years of research and so many publications and invited lectures, all the experience counts in, and you just pour in with knowledge. So once again, thank you so much, and we thank you, Dr. Kshitij, and for this very good platform wherein we could have a very good interactive session of webinar. So that's it from my side.
Thank you, Amol. It's been a pleasure, and thank you all again for staying late and contributing some phenomenal questions. I wish I could be live with all of you. As Amol knows very well, when I come to India, the Q&A session is actually longer than the presentation, and I love this part. And again, Dr. Kshitij, for moderating. You've done a wonderful job.
Thank you so much, Dr. Fadi, for the interactive session. And I know there's some patients waiting for you. We have taken enough time from you, your busy schedule.
Thank you.
Thank you once again for coming on the platform.
Thank you very much. Good night, everybody. Take care.
Good night.
Nice.
Thank you.
Thank you.